So today we will see the diaphragm. Diaphragm is a dome-shaped movable musculoponeurotic partition between the thoracic and abdominal cavities. It forms the roof of abdomen and it is the chief muscle of inspiration. And the position of diaphragm varies with posture, build of individual and phase of respiration. And in supine position, diaphragm is highest and show the maximum movements. And in quiet breathing, it descends for nearly 1.5 centimeters. Then surface, the superior surface is covered with the diaphragmatic pleura and there is the inferior surface covered with diaphragmatic fascia. And the inferior relations of inferior surface, on the right side it is related to right lobe of liver, right kidney, right suprarenal gland, and on the left side it is related to left lobe of liver, fundus of stomach, spleen, left kidney and left suprarenal gland. Then thoracic surface is convex on the right and left side, and summit of these convexities are known as cupola or dome of the diaphragm. And there is a depressed area in the middle. It is called as central tendon. Now origin, it is having a circumferential origin, that is sternal origin, costal origin and vertebral origin. The sternal fibers arise as two fleshy slips from the back of xiphoid process, and the costal origin is consisting of 6 fleshy slips from the inner surface of lower 6 ribs near the costal cartilage. Then vertebral fibers from 3 sources, that is a pair of crura, pair of medial arcuate ligament and a pair of lateral arcuate ligament. Now we will see the vertebral origin in detail. So here you can see the sternal origin, costal origin and the vertebral origin. So first of all, a pair of crura, that is there is a right crus and the left crus. Right crus is attached from the front of body and intervertebral disc of upper 3 lumbar vertebrae, and it is larger and it is having a prolonged attachment because it has to contract against liver, and it gives attachment to suspensory muscle of duodenum, which is attached to the duodenojejunal flexure. Then we have the left crus, that is from the body and intervertebral disc of upper 2 lumbar vertebrae. It is connected to cardiac end of stomach by gastrophrenic ligament. And both the crura are connected across the midline by median arcuate ligament. Then we have a pair of medial arcuate ligament or medial lumbocostal arch formed by thickening of psoas fascia from the body of L1 to the tip of transverse process of L1. Then a pair of lateral arcuate ligament or lateral lumbocostal arch formed by thickening of anterior layer of thoracolumbar fascia in front of the quadratus lumborum. And it is attached from the tip of transverse process of L1 to the lower border of 12th rib. Okay, here you can see the two crus and the medial arcuate ligament, median arcuate ligament as well as the lateral arcuate ligament. Now insertion, it is inserted into the central tendon which is trifoliate and it is having no bony attachment. And it fused with the central tendon, fused with the fibrous pericardium. It is having middle part and is right and left leaflet which is tongue shaped. And the right leaflet is short and the left is thin and long. Now coming to the openings in the diaphragm, we have vena cava opening at the level of T8, then esophageal opening at the level of T10 and aortic opening at the level of T12. Now the vena cava opening, we will see each openings, major openings and the minor openings. So major opening is the vena cava, esophageal and aortic opening. So the vena cava opening, it is at the level of T8 to the right of midline and it is quadrilateral and it lies in central tendon. Structures passing are inferior vena cava, right phrenic nerve and lymphatic vessels. Upon contraction of the diaphragm, the vena cava opening dilates. The esophageal opening is at the level of T10 and it is elliptical to the left of midline, and it is formed by the splitting of fibers of right crus of diaphragm. Then structures passing are esophagus, vagal trunks, left gastric artery, lymphatics, and phrenoesophageal ligaments. Then effect of contraction of the diaphragm on this opening is it prevents the regurgitation of food from stomach to the esophagus, and during inspiration the opening is constricted. So there is a sphincteric effect or pinch cork effect. Then we have aortic opening at the level of T12. It is a rounded opening posterior to the median arcuate ligament. Structures passing are abdominal aorta, thoracic duct, and azygous vein. And there is no effect of on this opening during contraction of the diaphragm. Then there are several minor apertures. One is the space of Larry between the sternal and costal origin through which superior epigastric vessels pass. When the opening is enlarged, it is called as foramen of Morgagni. Then we have the musculophrenic vessels passing between the costal origin from 7th and 8th cartilages. Then behind the lateral arcuate ligament, subcostal vessels and nerves. Then behind medial arcuate ligament, we have the synthetic chain. Then piercing each crus, there is a greater splenic nerve, lesser splenic nerves. And the right crus is pierced by the azygous vein, and the left crus is pierced by inferior hemiazygous vein. Then left phrenic nerve also pierces the left cupola. Now coming to the nerve supply, motor supply is by phrenic nerve, that is C3, C4 and C5, and it divides into anteromedial branch, anterolateral, posteromedial and posterolateral branch, and each crus is supplied by the corresponding phrenic nerve up to the margin of esophageal opening. Sensory supply, central part is by the phrenic nerve, peripheral part by the lower 6 or 7 intercostal nerves. Then sympathetic supply is by celiac plexus. It maintains the tone of diaphragm, that is by Orbeli phenomenon. Then we have the artery supply by musculophrenic and pericardiophrenic, that is branch of internal thoracic again. Then we have the lower 5 or 6 intercostal artery, superior phrenic artery, branch of thoracic aorta, inferior phrenic artery, which is a branch of abdominal aorta. Then coming to the lymphatic drainage, thoracic surface, anterior part is by the anterior diaphragmatic nodes and parasternal nodes. Then middle part of thoracic surface by right and left lateral diaphragmatic, parasternal and posterior mediastinal nodes. Posterior part is by the posterior diaphragmatic nodes and posterior mediastinal nodes. Then on the abdominal surface, the lymphatic supply of the right half is by the lymph nodes along the inferior phrenic artery and the left half by pre-aortic nodes. Now coming to the actions, it is the main muscle of inspiration. So when the diaphragm contracts, the dome and the central tendon will descend, and this will increase the vertical diameter, and the central tendon become a fixed point around which it contracts. This will elevate the lower rib and as well as push forward the sternum and the upper ribs. Thus there is increase in the transverse diameter and anteroposterior diameter. Then it raises the intra-abdominal pressure, and this is useful in expulsive activities like micturition and defecation, and it helps in weightlifting by sustaining the intra-abdominal pressure by closure of glottis, and thus it helps to maintain the vertebral column in extended position. Then another important action is facilitate the venous and lymphatic return, that is by increasing the intra-abdominal pressure and decreasing the intrathoracic pressure. This will compress the blood in inferior vena cava and lymph in cisterna chyli. Now coming to the development of diaphragm. So developmentally it is entirely mesodermal in origin. The main contributing parts are the septum transversum, dorsal mesentery of esophagus, right and left pleuroperitoneal membrane, and the projection of body wall. And the first three form the primordial diaphragm. Now, the septum transversum is the unsplit part of intraembryonic mesoderm in the cranial part of the embryo, and it is developed during the third week of intrauterine life, and it lies opposite to C3, C4, C5 somites. Now, after the formation of head fold, by the fourth week, the septum transversum migrates and it forms a thick incomplete partition between the thoracic and abdominal cavities, leaving large gaps. Now, dorsal to septum transversum, the dorsal, there is a esophagus and the mesenteries. So here you can see the esophagus and the septum transversum. Now, the dorsal margin of the esophagus is attached to the posterior abdominal wall by dorsal mesentery, and the ventral margin is of esophagus is connected to septum transversum by ventral mesentery. Okay, so we have the septum transversum and the esophagus, and and we have the dorsal mesentery of esophagus. Dorsally and ventrally, we have the ventral mesentery of esophagus. Then on either side of the esophagus, there is a pleuroperitoneal canal. And slowly this pleuroperitoneal canal is closed by the pleuroperitoneal membrane. So until then, when it is open, the pleural and peritoneal cavities will communicate to the pleuroperitoneal canal. Now, by the sixth week, the septum transversum expands and it fuses with the ventral mesentery of esophagus, dorsal mesentery of esophagus, and the pleuroperitoneal membrane. And simultaneously there will be contribution from the body wall by 9 to 12 weeks. Pleural cavity also increase and there is contribution from the body wall. So the pleural and peritoneal cavities communicate initially through the pleuroperitoneal membrane, which is later closed by the membrane, and it is separated from the body wall. So with the growth of the body wall, when there is expansion of the thorax and there is extension of pleural cavity into the body wall, and this forms the costodiaphragmatic recess of pleura. Okay. So main components that is of adult diaphragm, that is septum transversum, that is forming the central tendon of the diaphragm. So here you can see the components of adult diaphragm. Anteromedian part including the central tendon, vena cava and esophageal opening is developed from the septum transversum. Then right and left crust developed from the dorsal mesentery of esophagus, and the large peripheral part is from the projection of body wall, and small peripheral part is developed from the pleuroperitoneal membrane. Now the nerve supply is mainly by the phrenic nerve. So the muscles of the diaphragm develop from third, fourth, and fifth cervical myotomes. Now, when the diaphragm descends, the phrenic nerve is dragged, and hence there is a long course of the phrenic nerve. Now, descent of the diaphragm, which is contributed by the elongation of neck, descent of heart, and expansion of pleural cavity. By the fourth week of intrauterine life, the septum transversal lies at 3 to 5 cervical segment, and by the sixth week of intrauterine life, the diaphragm descends and lies opposite to T7 to T12. Then by the eighth week of intrauterine life, the dorsal part of the body of embryo will grow rapidly and it reaches the level of T12 L1. Now regarding applied anatomy, So most important part is the diaphragmatic hernia. It can be congenital or it could be acquired. So the congenital can be through the posterolateral triangle. So that is called as posterolateral hernia. Then retrosternal hernia, that is through the space of Larry. Then paraesophageal hernia, that is through the esophageal hiatus. Then we have the acquired, that is traumatic and hiatal or sliding hernia. According to some books, hiatal hernia is classified into sliding and paraesophageal hernia. So that is herniation of the abdominal contents into the thorax, and the lung will be hypoplastic in such cases. So commonest type of congenital diaphragmatic hernia is Bogdalik's hernia, and it is more common on the left side because the right pleuroperitoneal membrane closes early. And the diaphragm, here the diaphragm failed to arise from lateral arcuate ligament on both the sides or on a side. So there is a triangular gap that is called as Bogdalic triangle or the costovertebral trigone. Then we have the retrosternal hernia, that is when the space of Larry is enlarged. So that is called as foramen of Morgagni. So through this gap, the abdominal contents will usually herniate into thorax. Usually it is a transverse colon or omentum. Then another most important hernia is the hiatal hernia. That is through the esophageal opening. So we have sliding hernia. In sliding hernia, the gastroesophageal junction slide into the thorax through the lax hiatus in the lying position, and this is expressed as heartburn. Then in rolling hernia or paraesophageal hernia, the gastroesophageal junction remain in the normal position and the hernial sac containing the fundus of stomach project into the thorax by the side of esophagus. So the patient complain of pain, nausea and dysphagia. This is another classification for the congenital defect in the diaphragm. You can add along with the development if asked. So one is the posterior hernia, then posterolateral hernia, then central and retrosternal hernia. So abdominal contents can pass through these gaps and produce diaphragmatic hernias. Then diaphragm assumes an inferior level when a person is in sitting position. For this reason, the people who have dyspnea, that is difficulty in breathing, they prefer to sit up. Then we have the phrenic nerve avulsion. So this is usually done to paralyze one dome of the diaphragm to give rest to the lung of that side, and this was done usually in tuberculosis lungs. And sometimes you can have accessory diaphragm usually in the thoracic cavity, and it will subdivide the lung into two parts. Then we have eventration of diaphragm. Here there is elevation of the hemidiaphragm. It is usually due to the deficiency of musculature in one half, and the peculiar respiration which you see is the paradoxical respiration. That is, on inhalation the flail section or the chest will move inwards, and on expiration the chest will move outwards. Then we have hiccups, that is involuntary spasmodic contraction of the diaphragm accompanied by closure of glottis, and it is common in normal people. And other pathological causes could be diaphragmatic irritation, phrenic nerve irritation or uremia. Then shoulder tip pain is another. Whenever there is irritation of diaphragm, it is referred pain in the shoulder because the supraclavicular nerve and phrenic nerve is having the same root value. So that is all. Thank you and all the best.